Hi,
Hi,
my
my
name is
name
Brooke
is Brooke
Boer,
Boer,
and this
and
is
this
my
is my
geriatric
geriatric
syndrome
syndrome
case
case
study
study
for
for
spring
spring
2019.
2019. The
The
geriatric
geriatric
syndrome
syndrome
that
that
I
I
will
will
be
be
doing
doing
is
is
dementia.
dementia.
So,
So,
introduction
introduction
of
of
dementia.
dementia.
Dementia
Dementia
is a
is a
syndrome
syndrome
of
of
acquired
acquired
persistent
persistent
intellectual
intellectual
impairment
impairment
with
with
compromised
compromised
function
function
in
in
multiple
multiple
spheres
spheres
of
of
mental
mental
activity.
activity,
And
and
that
that
was
was
cited
cited
from
from
Malone
Malone
in
in
2014.
2014.
With
With
AD, the
AD, the
disease is
disease is
gradual,
gradual,
and the
and the
course of
course
the
of the
disease is
disease is
generally
generally
slow.
slow.
According
According
to
to
Kennedy
Kennedy
Malone,
Malone,
Fletcher, and
Fletcher, and
Plank in
Plank in
2014,
2014,
the
the
duration
duration
ranges
ranges
from
from
3 to
3 to
20
20
years and
years and
averages
averages
10
10
years as
years as
comorbidities
comorbidities
complicate the
complicate the
illness,
illness,
and that
and
can
that
be
can be
found on
found on
page
page
562.
562.
Alzheimer's
Alzheimer's
disease, or
disease, or
AD, is the
AD, is the
most
most
common
common
cause of
cause of
dementia.
dementia. A few statistics
Statistics
from
from
research.
research.
According
According
to
to
Kennedy
Kennedy
Malone,
Malone,
Fletcher,
Fletcher,
and
and
Plank
Plank
in
in
2014,
2014,
blacks
blacks
and
and
Hispanics
Hispanics
are
are
at
at
higher
higher
risk
risk
for
for
developing
developing
AD.
AD.
Women
Women
are
are
more
more
likely
likely
to
to
develop
develop
the
the
disease
disease
because
because
primarily
primarily
they
they
live
live
longer,
longer,
and
and
that
that
can
can
be
be
found
found
on
on
page
page
563.
563.
According
According
to
to
Alzheimer's
Alzheimer's
Association
Association
in
in
2019,
2019,
Alzheimer's
Alzheimer's
disease
disease
accounts
accounts
for
for
60 to 80% of dementia cases. It
it
is
is
not
not
a
a
normal
normal
part
part
of
of
the
the
aging
aging
process.
process.
Currently,
Currently,
AD is the sixth leading cause of death in the U.S.
according
According
to
to
the
the
Alzheimer's
Alzheimer's Association
Association
in
in
2019,
2019,
an
an
estimated
estimated
5.8 million Americans of all ages have Alzheimer's in 2019. 1
1
in
in
10
10
people
people
aged
aged
65
65
and
and
older,
older,
which
which
is
is
about
about
10%,
10%,
has
has
Alzheimer's
Alzheimer's
dementia.
dementia.
Almost
Almost
two-thirds of
two-thirds of
Americans
Americans
with
with
AD
AD
are
are
women.
women.
Older
Older
African
African
Americans
Americans
are
are
twice
twice
as
as
likely
likely
to
to
have
have
AD
AD
or
or
other
other
dementias
dementias
as
as
older
older
whites,
whites,
and
and
Hispanics
Hispanics
are
are
about
about
1
1
and
and 1
1/2
half
times
times
as
as
likely
likely
to
to
have
have
AD or other dementias as older whites.
According
According
to
to
Alzheimer's
Alzheimer's
Association in
Association in
2019,
2019,
as the
as the
number of
number of
older
older
Americans
Americans
grows
grows
rapidly,
rapidly,
so
so
too
too
will the
will the
number of
number of
new and
new and
existing
existing
cases of
cases of
Alzheimer's.
Alzheimer's.
By
By
2050,
2050,
the
the
number of
number of
people
people
aged
aged
65 and
65 and
older
older
with
with
Alzheimer's
Alzheimer's
dementia
dementia
may
may
grow
grow
to a
to a
projected
projected
13.8
13.8
million,
million,
barring
barring
the
the
development
development
of
of
medical
medical
breakthroughs to
breakthroughs to
prevent,
prevent,
slow, or
slow, or
cure
cure
Alzheimer's
Alzheimer's
disease.
disease.
People
People
aged
aged
65 and
65 and
older
older
survive an
survive an
average of
average of
4 to
4 to
8
8
years
years
after a
after a
diagnosis of
diagnosis of
Alzheimer's
Alzheimer's
dementia,
dementia,
yet
yet
some
some
live as
live
long
as
as
long as
20
20
years with
years with
Alzheimer's.
Alzheimer's.
The
The
first
first
symptoms can
symptoms can
appear
appear
after
after
age
age
60 and the
60 and the
risk
risk
increases with
increases with
age.
age.
Also, the
Also, the
number of
number of
people
people
living with
living with
AD
AD
doubles
doubles
every
every
5
5
years
years
beyond
beyond
age
age
65,
65,
and it's
and it's
projected to
projected to
nearly
nearly
triple
triple
to
to
14
14
million by
million by
2060, and
2060,
that
and that
is
is
cited by the
cited by the
CDC.gov
CDC.gov
in
in
2018.
2018.
The
The
significance
significance
of
of
dementia
dementia
to
to
the
the
nursing
nursing
profession,
profession,
according
according
to
to
Hansen,
Hansen,
Hogg,
Hogg,
and
and
Berglund
Berglund
in
in
2017,
2017,
taking
taking
care
care
of
of
psychosocial
psychosocial
needs
needs
is
is
viewed
viewed
as
as
a
a
central
central
component
component
of
of
high-quality
high-quality
dementia
dementia
care,
care,
in
in
which
which
tailored
tailored
and
and
individuals
individuals
care
care
beyond
beyond
meeting
meeting
physical
physical
needs
needs
such as
such as
nutrition,
nutrition,
medication,
medication,
personal
personal
hygiene,
hygiene,
and
and
domestic
domestic
chores
chores
is
is
emphasized.
emphasized.
Patients
Patients
are
are
at
at
risk
risk
of
of
being
being
isolated
isolated
and
and
lonely.
lonely.
Social
Social
contact,
contact,
confident
confident
relationship,
relationship,
and
and
meaningful
meaningful
and
and
varied
varied
activities
activities
are
are
factors
factors
that
that
must be
must be
emphasized
emphasized
to
to
increase
increase
the
the
quality of
quality of
life
life
and
and
well-being of
well-being of
patients with
patients with
dementia.
dementia.
Impaired
Impaired
cognition
cognition
of
of
neuropsychiatric
neuropsychiatric
symptoms are
symptoms are
common and
common and
have a
have a
negative
negative
effect on
effect on
quality of
quality of
life.
life.
Depression,
Depression,
anxiety,
anxiety,
apathy, and
apathy, and
irritability
irritability
are the
are the
most
most
common
common
neuropsychiatric
neuropsychiatric
symptoms of
symptoms of
dementia.
dementia.
As a
As a
provider,
provider,
it is
it is
our
our
responsibility
responsibility
to
to
ensure that
ensure
the
that the
patient
patient
has the
has the
best
best
quality of
quality of
life
life
when
when
they
they
have
have
end-stage
end-stage
AD.
AD.
We
We
have to
have
be
to be
supportive of
supportive of
both the
both the
patient
patient
and their
and their
family
family
members
members
to
to
ensure that
ensure
the
that the
patient is
patient is
comfortable
comfortable
and
and
all of
all
their
of their
medical
medical
needs are
needs are
being
being
met.
met.
The
The
patient
patient
is
is
a
a 68-year-old
68-year-old
male
male
whose
whose
current
current
living
living
situation
situation
is
is
in
in
Benton,
Benton,
Tennessee,
Tennessee,
in a
in a
one-story
one-story
home.
home.
He
He
lives with
lives with
his
his
wife of
wife of
46
46
years,
years,
their
their
two
two
male
male
puppies,
puppies,
as
as
well as
well
3 horses and several barn cats. He is allergic to sulfa medications, bananas, and kiwi fruits. You can see the list of his current prescribed medications below. He reports receiving all childhood immunizations. He received the influenza vaccine in 2018. He also received weekly allergy shots for 2 years. His last one was in 2015. All of his current immunizations are up to date. His last Tdap was in 2018. Pneumococcal vaccine was 3 years ago, and the herpes zoster vaccine was 3 years ago. As you can see below, the patient had chickenpox when he was 5, scarlet fever when he was 6. He currently is a type 2 diabetic, has hyperlipidemia, hypertension, chronic back pain, and diabetic neuropathy. He denies any recent hospitalization, last hospitalization was in 2003 for his cardiac stents. He currently does CrossFit type workouts. They are 1 hour every other day except on Sundays, and he is currently training for his first half marathon that he will run this September. And as you can see listed below is all of his preventative screenings that he has had recently. According to Alzheimer's Association in 2019, the patient may have problems with short-term memory, keeping track of a purse or wallet, paying bills, planning and preparing meals, remembering appointments, or traveling out of the neighborhood. The patient will present in the early stages with memory loss, which could be mild, and with late stage, the individuals begin to lose the ability to carry on a conversation and respond to the environment. The patient may complain of difficulty sleeping or change in their sleep pattern, difficulty concentrating, trouble with their thought process, difficulty focusing or paying attention, etc. The ROS, psychological, neurological, cognitive, cardio, endocrine, respiratory, general, and a complete review of the patient's medications. The only negative is that the patient does take Percocet, and he admits that he has been more forgetful than normal, and he has developed some new difficulty sleeping. All other ROS are unremarkable with no complaints. Listed below are the patient's vital signs. Overall, his general appearance was well-appearing, ambulatory on arrival to the clinic without any assistance in the presence of his wife, appears to be stated age. He is awake, alert, oriented, and no obvious acute or distress. I completed a mental status exam. Cognitive function tests were completed, as well as a psychosocial review. Also, a functional assessment was completed. General physical exam included cardio, respiratory, neurological, eyes, ears, coordination, and musculoskeletal exams were also done. At this time, the patient does not have any negatives except for his MMSE score, which is 22. He also has a family history of dementia, and he has a hard time remaining focused during the exam. Other than the negative findings, his exam was unremarkable. The screening tools used and tests to be ordered. I completed a home safety assessment checklist, which he scored a 2. The fragility assessment, which he scored a 0, the MMSE, which he scored a 22, the depression screening tool, or the GDS, which he scored a 3, and according to Alzheimer's Association in 2019, there is not one test to determine if someone has dementia. They diagnose it based on careful medical history, a physical exam, lab tests, and characteristic changes in thinking, day-to-day function, and behavior associated with each type. The labs ordered were a CBC, a lipid panel, hemoglobin A1C, CMP, BNP, fasting, blood sugar, PT, INR, BUN, creatinine, LFTs, vitamin B12, and vitamin D, and also he had a head CT scan ordered to rule out an acute bleed. The treatment of dementia depends on the cause. In the case of most progressive dementias, including AD, there is no cure and no treatment that slows or stops progression. You also want to treat the underlying medical conditions. As you can see, cited by Brook in 2016, there are a few different cholinesterase inhibitors that can be used, or you can use Exebia. You can also treat with a few different things, which include psychotherapeutic interventions, biological interventions, social interventions, family interventions, managing non-cognitive behavioral symptoms, and non-pharmacological approach, and that was cited from Malone, Fletcher, and Plank in 2014. A few differential diagnoses associated with dementia include depression, vitamin B12 deficiency, hypothyroidism, and head trauma related to injury, and you can see below how I ruled out each of the differential diagnoses. The final diagnosis for this patient is early dementia. The patient's mother has dementia and was diagnosed when she was 70. The patient also scored a 22 on the MMSE. He was unable to complete the serial 7s and forgot the 3 objects he needed to repeat. The patient is unable to remain focused while he is trying to drive, shop, or do his workouts, and his wife states that he is becoming more forgetful. She stated that he recently forgot a few important doctor's appointments and that she has to keep him aware of them. She also stated what really worried her is when he forgot about his grandson's baseball game, which he has never missed one game. The patient stated that he is beginning to have a hard time remembering the workouts, and someone is always having to remind him what to do next. He also states that he is having some trouble sleeping and staying asleep. Also, all his labs came back within normal limits, and his head CT was negative and unremarkable. A few challenges and barriers to the plan could include: unfortunately, in the early stages, there would not be as many challenges and barriers. And currently at this time, the patient does not exhibit many challenges except becoming more forgetful lately. However, in the later stages, the patient becomes more forgetful, leading to a decreased ability to drive, decreased ability to complete ADLs and IADLs, unable to make decisions for themselves, unable to care for themselves, and can eventually develop aphasia, anomia, agraphia, alexia, apraxia, agnosia, and mnemonic disturbances. And some barriers, according to Sachs, Shuga, and Cox and Haley in 2004, dementia is not seen as a terminal illness appropriate for palliative care. The nature of advanced dementia and treatment decisions, psychological and emotional challenges, assessment of pain if cognitively impaired, managing behavior and psychiatric issues, caregiver stress and bereavement issues, and economic and systemic disincentives for providing end-of-life care. Resources recommended for the patient would be to attend a support group for patients with dementia. They can help him with any questions he has and help him to cope with the diagnosis. It is also very beneficial for his wife. They have groups that are online and they're 24/7 if she ever needed any support. Also, if the dementia got into the later stages, it would be important to ensure that his home environment is safe, set up hospice, home health, be sure that he and his wife have all the supplies that they need to care for him at home. You can include a neurologist, a geriatric, psychiatric, NP or MD as needed, and the PCP. If there's any type of underlying conditions which could be causing the symptoms or is having any other issues, then he needs to be seen by cardio, respiratory, GI, etc. So for the discussion, a few health behaviors include daily exercising, decreasing alcohol intake, eat a healthy diet, and maintain low body weight and BMI. It also recommends that they not smoke, but the patient currently denies smoking. The patient has adequate social support. His home environment is safe for him. He has adequate access to health care. He is not exposed to crimes and feels safe in his neighborhood, and he has community resources available as needed. According to Toro in 2014, socioeconomic status may contribute to the higher rate of dementia seen in African Americans compared with white older people. Socioeconomic disadvantages experienced by older Black people lead to fewer educational opportunities, which may explain the increased rate of cognitive decline. Other studies have shown that education and literacy may be protective factors against cognitive decline. And currently, this patient, he attended UTC and obtained a bachelor's degree, he says, many years ago. In general, variable premorbid level of activity in education, believing that dementia is normal aging, reluctant to seek assistance are all influences of culture on dementia. If a patient with AD does not have some type of advanced directive in place for their health care or their financials prior to the end stage of the disease, then the healthcare professionals or the family will not have any idea as to what type of care the patient wants to receive. And it can lead to legal issues for the family as well as ethical issues. For example, if the patient has it set in his mind prior to the end of stage that they want to be a DNR and have made their family aware, but they have not made a plan or had a living will wrote up, when they do reach the end of stage of the disease and they are in need of an emergency medical help, then I feel as though you are going against their will, since that is not what they would have wanted. In conclusion, during this assignment, I learned that in caring for a patient with AD, it is important that they have a living will in place, or at least some type of plan or even a power of attorney in place, because once in the end stage of the disease, when they are unable to communicate, they begin losing their memory or become forgetful, then as a provider, we have to have some sort of idea of what type of care the patient is wanting to receive. As a provider, we should provide the patient and the family members with the proper resources and guidance as the disease progresses and becomes more demanding on the family. We should instruct the patient and family on the importance of being proactive and the importance of making a plan for health care and finances, because everyone needs to know what the patient's wishes are. I feel as though the care can be evaluated at frequent intervals to ensure that it is still what the patient wants. It is also important that the family be included in the care and be updated on the disease progress. The last 2 slides of this PowerPoint are the references I used throughout this presentation. I want to thank you for listening and looking through my PowerPoint on dementia.